Hello and welcome. We are so pleased to have Dr. Peter Leo to the podcast today. He is the Clinical Assistant Professor of Dermatology and Pediatrics at Northwestern's University Feinberg School of Medicine, where he founded the Chicago Integrative Eczema Center to provide treatment and education for children with atopic dermatitis. In his clinical practice at Medical Dermatology Associates of Chicago, Dr. Leo works to integrate complementary medicine approaches, such as acupuncture, to treat his patients with atopic dermatitis, acne, and other inflammatory skin diseases. Thank you so much for joining us today, Dr. Leo. Can you tell us about the number of emerging therapies for the treatment of atopic dermatitis in pediatric patients and how this has changed the treatment landscape in general?
This is such an exciting time for atopic dermatitis, both in adults, but also, of course, in our pediatric patients. There has been this very long drought of new therapies for essentially my entire career. And now in the last couple of years, and particularly this year, we are seeing what is a literal bonanza of new treatments and new ideas. And of course, when we get new therapies, that also informs us a little bit more about the disease itself. So I talk about this idea of a virtuous cycle of drug development. As we get new, especially more targeted treatments, we learn more about the underlying condition, and that often leads to more and more targeted treatments that we can use for the same condition. So really exciting. There are over 40 or 50 different treatments, and maybe, depending on how early on you look, maybe as many as 100 different treatments finally in the pipeline for atopic dermatitis. Many of these will be studied in pediatric patients. Some of those will not be studied immediately or may not come out of the gate with a pediatric indication, but eventually some of them may. So a lot of times in pediatric dermatology, we're so used to not having specific medications for most of our conditions, right? Like any condition in dermatology may or may not have anything FDA approved. For example, lichen planus, right? That's a fairly common condition dermatologists we see. There is no FDA approved medicine for adults or for pediatrics. Other things may have an adult approval, but we end up having to use them off label for the same condition in pediatrics. So we're kind of used to that. That being said, several of the new medicines that have just come out actually do have pediatric indications. One of the ones, of course, is the topical JAK inhibitor, topical ruxolitinib, which really got its approval at the end of September in the United States. And that is actually approved down to age 12 years. Very exciting. And then there have been a couple of new oral JAK inhibitors that have been approved. And one of them, upadacitinib, also has a pediatric indication down to age 12. The other one, abrocitinib, is technically only approved for adult patients right now, but I actually think that we will see a pediatric approval, or at least I hope so, because they've done similar studies in the 12 to 18 age range. So hopefully we'll get that as well.
Wow, it sounds like your research has done amazing things. So what is your personal approach to treating atopic dermatitis in pediatric patients?
It is such a difficult disease to treat, right? We know it causes a tremendous amount of suffering. The burden of the condition is really high, not only for the patients, but also for their whole family. And that effect continues to ripple out. It affects school and work and the rest of the family. It even affects us. Clinicians take some of that burden on because it has a huge impact on their life. So I think our general approach in kids is essentially the same as the general approach in adults, but with pediatric patients, the stakes are a bit higher. Some of the things that we have to worry about are the fact that kids are still developing, so we don't want to use anything that could cause changes to their development or growth. The other thing is that in general, our tolerance for side effects is lower in kids, as it should be. We're not willing to deal with as many risks or concerns because these are, in general, more, they're patients who are a little bit more at risk and more fragile, more delicate. So I think the general approach is to first try to make sure it is atopic dermatitis. Once we've gotten that down and we know it's not, for example, things that can look similar and even kind of mimic it, or can also complicate it, would be things like allergic contact dermatitis. So let's say, for example, you're allergic to a soap or a cleanser, or even one of the moisturizers that you're using. This can make your skin look worse and worse, be itchy, uncomfortable, red and scaly. And for some patients, that actually can mimic atopic dermatitis or be one of the driving factors. So once we've made sure, okay, this is atopic derm, the first thing we try to do is make sure we're removing any known allergens, irritants, or triggers that could be making it worse. For some people, maybe if they get hot and sweaty, then it gets worse. So we might try to counsel them. Can you make sure that you're avoiding those situations? Or if you do have to get sweaty, take a shower quickly and moisturize. For other patients, it might be a fabric. Wool is notorious, especially older types of wool. Some of the newer wools, I will say, they've gotten it refined to a point where it's much easier on the skin. But classically, if you put a wool sweater against someone's skin with atopic derm, they feel itchy and uncomfortable. And it's due to the microscopic nature of those wool fibers. Certain things like fragrance products or things that are exfoliating, things like that. So we want to try to avoid those things first and foremost. And we want to do good, gentle skincare, good moisturization, gentle bathing practices. If we do that, many patients who are in the mildest group, they're actually great. And that's my dream. I don't want to have to give anybody medicine, right? We just want people to feel good and be able to go about their lives. We'd like to make eczema from being the main thing they're worrying about all the time. I'd like to put that in the distant background. They have other stuff to do. We got work to do. So our job is to try to get it out of the way. And if that's enough, perfect. The next step, though, if that's not enough, is to be reactive. So we're going to give them something to cool down the skin when it's flared up. We're going to try to help with the inflammation, the itch, and the damaged skin barrier, which then we think secondarily will help with the microbiome. Typically, we'll use topical corticosteroids in both adults and kids as our first line, even though they have some serious risks. And some patients I have say, I don't want to use them. I'm afraid of them. I don't like them. The reason I think they've persisted so long is we've had a long history with them since really the 1950s. And they're sort of the devil that we know. They have clear side effects that can cause trouble, but we also have a pretty good sense of when those are going to come out. And we know if we use them safely, generally speaking, most people tolerate them very well. It also turns out that they're extremely reliable. Some of the newer medicines, they can work very well, but they're less predictable. And we'll talk about that in a little bit. But sometimes I'll give a medicine to a patient, they call me a week later and say, Doc, it's not really doing anything. So now we've lost a week of time. We've spent money. Many of these treatments, the newer treatments, are very expensive too. And that underscores the last part of topical steroids. They're accessible. They're very cheap, and almost any patient can get them, insured or not. But especially if you have insurance, generally it's going to cost next to nothing to get steroids, as opposed to some of the newer treatments, maybe much more difficult. So if we can be reactive and patients can use them carefully, briefly to get control and then take a break, I feel like, again, we've all won the game. We've put very little risk, very little money has gone into it, very little time, and we're happy. What if that's not enough? Well, that's basically where my job begins. I really am only seeing referred patients now. So every patient that I see by definition has tried these things in some form or another. Sometimes, many times they've tried it. And we really then have to start thinking out of the box. And that's really where all the unmet needs happen. Are there safe, non-steroidal topical medicines that we can use to help treat a flare or maintain clear skin? Are there systemic medicines, be it shots or pills, that we can use to help those patients who are so severe or have so much body surface area? It's like, well, I don't have enough cream. I'm burning through 2 tubes of cream every week because it's most of my body. So all of these things then are what we're thinking about. And some of the discussions we have, what about the role of light therapy? What about getting additional allergy testing? Do we need to understand if there are other environmental things playing a role? What about even in some of the crazier cases, I've had patients actually go to get balnea therapy, spa therapy. We had a family go to France for 2 weeks and get spa therapy there, which was amazing and really made a difference in her life. But not everybody can do these things. And so we start to ask.
So what would that do for her specifically? What did you recommend that for? That's so interesting.
She was a pediatric patient who is really suffered, and we've tried so many different things. And they're in France, they actually have several of these balnea therapy spa centers. Now, they sound really glamorous. In fact, in my conception of it till I went there was that it was going to be like everyone wearing plush robes and relaxing and sitting by pools eating bonbons, but it's absolutely not. It actually feels quite a bit like a hospital setting. It's quite clinical, and people wear white coats, and a lot of it is actually they're spraying you down with the water. I also thought you'd be floating in a cave or something, but no, they're spraying you down. But the water is they're mineral rich waters. And actually, they really do seem to have a positive effect on skin barrier and also on the inflammation. I think also of course, the environment is lovely. You're in a relaxing environment. You break out of your normal routines. There's a team of doctors and nurses helping you. Anyways, it was pretty transformative. It helped.
That's amazing. Really
so
amazing.
These are some of the crazy things we'll do, right? And then, of course, for patients who can't do that, and especially it's not covered in the US, although it actually is part of the health services in France. You can do that for, I think, up to 3 weeks or something as part of your government given insurance there. But in the US, we might then go to our systemic therapies. And we've had some historical systemic therapies like prednisone and cyclosporin and methotrexate and azathioprine, and of course mycophenolate. Those have been the classical ones. And then more recently, we've gotten our biologic agents, dupilumab, and then very recently in that group, we now have tralokinumab, another biologic agent. The former does IL-4 and IL-13 inhibition via receptor. The latter actually binds to IL-13 directly. And then very recently, just in the last few weeks, we have two new oral agents that are pretty exciting. And this includes upadacitinib and abrocitinib, and they're both in the JAK inhibitor family. So now we actually have quite a number of treatments that we can use for those patients that have climbed that ladder and we're still having trouble.
Wow, that's truly all really cool and amazing information. Thank you for sharing that. What made you decide to focus mainly on children and also to found the Chicago Integrative Eczema Center? I mean, that's a pretty specific thing, and you must have a story surrounding that, right?
Absolutely. You know, I think I really do love taking care of both adults and kids, but with kids in particular, they've always really kind of pulled at my heartstrings because I think the suffering is different. These little guys don't always understand what's going on, and sometimes they don't have the best family support either. So I do feel that our pediatric patients are particularly vulnerable, and I really like to help them as much as I can whenever I can. I just hate to see anyone suffer, but it's that much more when it's a younger patient or even a baby. So my first year after residency, I spent a year doing pediatrics, like formal pediatrics internship at Boston Children's. It was a wonderful experience. And then when I did my dermatology residency, I was still in Boston at Harvard, I kept my continuity clinic at Boston Children's with two of my favorite mentors in the world, Steve Gellis and Marilyn Liang, two of the best pediatric dermatologists ever made. I think they're the best. You know, they're just the paragon pediatric
So
derm.
they were your inspiration. Very cool.
They were my inspiration. They're my mentors, and I still look to them even today for support and advice and ideas because they're brilliant clinicians and great people. So that was great. And then I realized that I also like integrative approaches to healthcare. I studied acupuncture formally after I finished derm residency, and in part because I wanted more tools, more options, more approaches, and better understanding. And that was incredible. And there I have to thank two of my teachers, Kiko Matsumoto and David Euler. They're amazing acupuncturists and great clinicians. They really take good care of their patients. And that also had a huge effect and inspiration on me. So I decided that I wanted to bring more of these approaches in and study them more formally, and kind of started down that path. And about now 6 or 7 years ago, we started the Chicago Integrative Eczema Center, a center just focused on using these combination approaches to get people better who are in need. And it's been such an exciting journey, and I've met wonderful people from all over the world, and it really has been incredibly rewarding.
Wow, so you must be pretty busy all the time. That's
It
amazing.
is, yeah, we stay out of trouble, right? No time to dwell or get into trouble.
Well, that's good. Would you mind sharing some advice for dermatologists on communicating with parents and possibly caretakers of pediatric atopic dermatitis patients regarding possible treatment options?
Absolutely. I think the first thing I'll say is that we all have to come to an agreement that it is important to treat this condition, that untreated atopic dermatitis is actually pretty terrible. So a lot of times we're trained to talk about the side effects of a treatment, you know, the risks of a treatment or a medicine or an approach, but we forget sometimes to talk about the risks of no treatment. And with this condition, there are some serious problems that we see. One of which is, of course, the impact on sleep. I don't think it's controversial at all. Any family who has somebody in that family with bad AD knows that sleep is messed up. It's hard to fall asleep. Many people get up during the night, itchy and uncomfortable. And some people, even if they sleep through, their sleep quality is really garbage because they're scratching and uncomfortable all night long. All of these, again, I don't think it takes a lot of, in many more studies, I think we're pretty convinced that this damages people. This affects their development, it affects their behavior, it affects their mood, it affects their outcome of quality of life, right? So many different things. So if for no other reason than to get good sleep, we need to treat the skin. But there are many other reasons. We also know the microbiome is damaged on the skin and in the gut. We know that the skin barrier is damaged. And when that happens, we think that allergens, irritants, pollutants can keep getting into the body in an abnormal way, which probably not only fuels the inflammation and probably makes things worse, but also may put people at risk to developing new allergies. So one of the current thinkings about how people get allergic to some foods, in particular peanuts, is that is if you have broken skin barrier, there's peanut dust in the environment. There's food particles floating around. So if they get in an abnormal way, you then can develop a true food allergy, a life-threatening allergy to things like peanut. So again, it even puts the stakes even higher. Got to get this skin barrier healed. We got to get things back together. So that's step one. Once we agree we have to do something, then I think we have a number of options now. I'm excited to say we have a number of options to really start going through those and discuss them in what I like to call, and what's been called, I've learned this, the shared decision-making approach. So together, we're going to talk about the risks, the benefits, the pluses, the minuses, and go through them and work that out together and get feedback, make sure the patient and the family understand. Most importantly, make sure they're comfortable, because if they're not into it, if they're not excited about it, they're less likely to do it. And if they don't take the medicine, what's the point, right? If it sits on the shelf and nobody's actually using it, then it's not going to help anybody. So we really have to be all in on that. And I like to tell stories. I think that's an important way for us to understand risks and outcomes and experiences, because stats are really hard when you just show percentage, how many such and such events per 100,000 person years. It's like, what does that mean? I don't really know. But if you tell it in the form of stories, I did have a patient who had an infection, or I did have a patient who had eye issues with it. Let me tell you what happened. I think that can bring it down to earth. I also recommend there are a lot of online resources. So I am a proud board member of the National Eczema Association, a wonderful group that is focused on education and access and support for patients with atopic dermatitis and all forms of eczema. And they have all sorts of great resources. It's nonprofit. There's no branding or anything. You can go and learn. So I'm big on handouts. I'm giving my patients a lot of handouts. And sometimes I'll say, take some time, read through it. Let's think about it together. And then we'll talk about it. And sometimes they'll bring me, they'll say, we talked to my cousin, my sister, the pharmacist, our pediatrician, and they were worried about X, Y, and Z. And I said, great. All right, let's engage that. Let's talk about, that concern, because again, I want to get it out in the open before we do it. The worst is when they seem okay and okay, that sounds fine. Then they call me that night and they say, now we're scared. We read the prescribing information and all this caught us off guard. Then I think everybody loses, right? We lose because now we're delaying treatment. We also now are not face-to-face anymore. We had that opportunity in clinic to talk, and now we're trying to do it by phone or by portal messages back and forth. And of course, I think that also it shakes faith in the patient.
Everything you just described is what a patient wants from their doctor. That's so wonderful that you're so accessible and that you just work with them to create the things that are necessary, even depending on how much time it takes. It doesn't matter, because some doctors aren't like that. And that's a really wonderful thing that you're doing. So also, what tips do you recommend to your patients to manage their skin diseases?
There are so many cool little tips out there. I'll tell you a couple ones that are easy and really safe and accessible that I've loved in the past couple of years. One of the ones is to do something called a wet wrap. And the wet wrap therapy is really powerful. What it would be is, let's talk about wet wraps. Let's say you have bad eczema on your hands. So we'll focus on there, but this can be applied to anywhere on the body. Mm-hmm. You might at nighttime wash your hands gently, put on your medicine, and then your moisturizer. And then you take a pair of, let's say, cotton gloves, like soft cotton gloves, like Walgreens or CVS will even have boxes of them that are semi-disposable. Mm-hmm. You can usually use them for a few nights. And you put them in the sink, dunk them, wring them out so that they're just a little damp, and then slide on that damp glove. Now it feels gross. You have greasy, medicine and then these wet gloves. But then you might take some socks, just like a nice, fresh, clean pair of white socks, pull it over so you have a nice, warm, dry layer, sleep like that. When you wake up, what you'll find is that the dampness, first of all, it's nice and cool. So it cools the skin, but it also dampness kind of pushes and hyper moisturizes the skin and pushes that medicine deep, deep down. So many people, when they wake up from that, they're like, wow, it's transformative. We can do this for the feet. We can even do it for the body. People will do like a long sleeve t-shirt. And babies, we might do it with a onesie. So wet wrap therapy ideally should be used under guidance, of course, with somebody, but you can even do it for a few hours with a moisturizer. That's not dangerous necessarily. So you can do that just as long as you keep the room nice and warm. We don't want people to get a chill. And we have to be a little careful. If you do it too much, you can actually start getting little pimples and breakouts, like it can cause a occlusive folliculitis, but really nice. Another thing that I like, another easy pearl that a lot of my patients like, is something called the black tea compress. So you would literally just get some plain old black tea, simple black tea at the grocery store, mm-hmm. and you'd brew up a cup, and then you can either drink that cup or pitch it. And then you'll brew up the second cup with the same bag. So it's a second steeping, a little weaker. That second bag, the second cup of tea is a little weaker. And then I tell my patients, brew that up for about a couple minutes and then put that in the refrigerator, let it get nice and cool. Now you have your compress. So you take a little gentle cloth, dunk it in, and then you can use it as a cool compress with that dilute tea. And it feels so good. It's so soothing. There was a nice paper out of Germany showing that it helped tremendously with face dermatitis, eczema, and contact derm. And they can do that a few times during the day.
Wow, that's an amazing tip. I'm going to have to try that. It's great to have just redness go away or anything for eczema or rosacea or anything. So that sounds great.
Very soothing, yes.
Do you do that as well? Sometimes
I do.
You do.
I do. I recommend it, and I've used it on my own family members for sure.
Yeah, that's very interesting. I've never heard of that. So thank you for sharing. Also, I just have to ask, if you could be known for one thing, what would it be? It can be in your personal life or your medical life or both, whatever you'd like to share.
That's a very deep philosophical question. I guess I just would like to be known for being a really good person. I'd like people to say, when I'm long gone, wow, he was really good. He really helped others and did his best. And that means a lot to me. That kind of accountability and being there for people means a lot to me.
Well, that's definitely a wonderful answer. Thank you for all of your insight today. It's been a pleasure speaking with you, and I can't wait to share this podcast with everyone and have them listen to all these wonderful tips and tricks you've shared.
My pleasure. I hope to talk to you again soon. Have a great day.
Thank you. You too.